Okay, just to continue through this, part of the cure and control issue is to really try to remove as much tissue as possible and spare the normal tissue. Get clean tissue margins, meaning a good space around the tumor itself of other type of tissue that sort of insulates the tissue that removes by removing that. And then trying to look at making sure that there's not lymph node involvement, and kind of looking for any abnormal tumor marker values. Some of the types of surgery that this kind of would cover, sometimes like radical neck dissection, where they go in and take out a section but aren't able to remove everything. A lumpectomy might be done. A mastectomy could be done, with the idea that you're trying to cure and control the development of this coming back. Other things like hysterectomies or oophorectomies or thyroidectomies, a lot of different types of surgeries where they take out specific tumor sites or specific parts of, say, like a lung, like a pneumonectomy would also be a good example. So also you will see this term debulking procedure, and what that means is you're getting the bulk of what you can remove, and then like what would the benefit of that be? The idea is that the tumor size will actually be much smaller, and it may improve actually how other therapy can actually get into the remaining tumor, whether that's followed by chemotherapy that then kind of goes through the vascular system to get to that open area, or through radiation to kind of get closer to the source. So actually debulking is often a very common procedure to try to make chemotherapy or radiation therapy more effective. And from a palliation standpoint, sometimes debulking is done just to relieve the pressure in a specific area of growth of the tumor. So support and palliative care, of course, this is cure or control is not possible anymore at this point. So sometimes trying to talk about palliative care with families is not easy. Their ideal is to be able to preserve the quality of life, and then provide other supportive care, things like giving someone a feeding tube or creating a colostomy, or different ways that their body functions can still be maintained. Placement of a venous access device, say they go into the liver and just take out some of the liver lesions. They can't cure it, but they can make it more comfortable, and the person can feel better following that type of surgery. And then, as we've talked about in class before, about the ability for them to go in and draw off fluid where there's fluid built up, such as in the abdominal cavity sometimes, or around the lung, that external fluid that has built up from a cancer tumor in a body cavity presses in on other organs and creates a lot of discomfort. So the sad thing about that is often you go in and you do some type of a procedure to remove that fluid and aspirate it off, but it will gradually build up again. And in some cases, people will actually have a type of a drain that is put in permanently, and then it can be periodically, just instead of actually putting a needle through every single time, you have more of an ongoing way where you can drain some of the fluid off for a period of time and relieve some of the pressure, and then come back to it at kind of set intervals for kind of letting some of that pressure off. So chemotherapy, you're going to hear more about that from Ms. Cade. It's where we use chemicals as systemic therapy, meaning going through the vascular system and the blood vessels to get actually to the target areas. The goal is to reduce the number of malignant cancer cells in the tumor site. And this is the mainstay for most solid tumors and for cancers of the blood, what we call hematological cancers. So that is pretty standard therapy. And the thing to really think about there is there have been so many research studies done on chemotherapy and every type of cancer that there is pretty much out there, because we do tons and tons of cancer research in this country. We have a national council that actually has got very set parameters on every type of cancer. So when you go to an oncologist to get and find out you have cancer and you're told that you've got to receive chemotherapy, they're going to say you need this drug and this dosage at this often of intervals, and this many times you're going to have to take it over this many weeks, and then you switch to a different drug following this. They have done so much research now that they can tell precisely from all the ones that have been tested which regimens of different drugs in different time frames are the most effective at killing very specific types of cancers for many of the cancers. So it's not that your oncologist says, oh, well, I kind of like to do this one treatment this way. In reality, most people with the same stage cancer these days are going to go to an oncologist, and they're going to get treated with chemotherapy in a pattern that's very specific to that type of cancer in the most effective way. So that's good. And if that's not effective, then they may be a candidate more for what we call a clinical trial, where they're testing a different type. Pardon my dogs. So the goals of chemotherapy, of course, are cure, and you can kind of see some of the things that may fall under that in terms of cure, the types of cancers. Chemotherapy may also be given for control of breast cancer after surgery not coming back, or just to kind of keep breast cancer that has metastasized from growing out at a faster rate. You can see that small cell lung cancer is often chemo's given to control it, as well as ovarian cancer. And then for palliation, chemotherapy can be given to kind of shrink tumors or keep them from being as uncomfortable to someone. Can be given. Sometimes it helps relieve an obstruction that's in the body that's causing problems. And sometimes it just makes someone feel better. So there's different types and reasons that chemotherapy would be given for different types of cancers. The big reason that certain drugs and factors are kind of reviewed is each type of cancer has a certain cancer cell has a certain mitotic rate in the tissue of origin. If you have a kind of cancer that has a very rapid mitotic rate, and what that means is how frequently that cell is dividing and making a new one. Typically, those types of cancers have a better response to the chemotherapy. Smaller tumors usually respond better than large tumors, and the age of the tumor, if it's a fairly new, smaller, that hasn't had as much growth to it, and hasn't been in the body as long in terms of size, tends to have a better response to chemotherapy. So that is the reason that we try to really encourage folks to really try to identify problems with those 7 warning signs of cancer, so that if you've got that kind of cancer that falls in those categories where it's caught early, it's small in size, and it's a type that the cell divides fairly often, you have much more better chance of curing the cancer. Other factors in response, the location is important. There are very few chemotherapy type drugs that cross the blood-brain barrier. We'll learn more about that when we talk about the neurovascular system next semester. But suffice it to say that lots and lots of times when there is a brain cancer, that's what makes it very, very difficult to treat with chemotherapy. Is there's hardly any agents that we use that will go through that and actually get through the circulation to the brain to affect killing the tumor cells. There can be presence of resistant tumor cells that just don't react. They're kind of resistant to the effects of chemotherapy. And if a tumor cell becomes resistant to a certain kind of chemotherapy, just like germs become resistant to antibiotics, they pass that resistance on to their daughter cells when they split and grow into more. And so often that's a very negative sign, and the chemotherapy won't be effective from an ongoing standpoint. And then you will see them change sometimes from one drug to a totally different drug to see if they can, bypass that resistance that has developed. Big things from nursing in terms of preparation and handling of chemotherapeutic agents. In a lot of the facilities, you will have a chemotherapy team of nurses that mixes these agents, and sometimes it's pharmacy that mixes these agents because they are a hazard. Many of them have to have very strict guidelines because they technically can cause the person touching, breathing, handling it to be carcinogenic themselves or detrimental to your tissue and your cells. So it's important to know that there's very precise ways that these are handled, and only properly trained personnel should be able to handle these drugs. So if you do become a nurse that does treat cancer patients, you will have to go to specialized training to know how to do that. And when these are disposed of, they can't go in the regular trash. They have to be put in a chemotherapy specific type of waste disposal on a unit. And so important things to know, even in providing care to somebody that you might get assigned in clinical. Somebody could actually be receiving chemotherapy, and you may or may not know that. You want to be sure that you know what you're doing and being safe when you're in there. Chemotherapy can be given in a lot of different ways. We kind of think about the traditional IV method because it's most common, but there are some chemotherapies that can be given oral. There are some that can be given intramuscular. Some of them are given intracavitary, or intrathecal, and even intraarterial. And I will show you some examples of some of those different things as we go through this. This is, we talked a little bit about in class about IV therapy and extravasation. So here gives you a good picture of what having extravasation injury due to chemotherapy in a peripheral IV site can actually look like. So when I say that it is really a horrible, horrible condition that creates a huge gaping wound, this gives you a good example of what it can look like. And so this has just got to be treated as a wound following this. That is why you see so much use of patients getting portacath or a PICC line inserted prior to them beginning a chemotherapy regimen, is because many of these agents, you do not want them to come outside of the skin or under the skin in an infiltration, because this is what will end up creating a huge wound and issue for you.